Thank you, Professor Pandey, and the organizers of the 21st Microneurosurgery workshop. Today, I feel honored and privileged to be a part of this workshop with the celebration of the 100th birth anniversary of the legend, Professor B. Ramamurthy. 3 years ago, Professor Sanjay Bihari asked me to write a commentary on an article published by Professor Ramamurthy in 1970. This article was on his experience of operating on 122 cases of vestibular schwannomas. By reading that article and putting a commentary to that, I realized how visionary he was and how much ahead of his time. I am happy that I have been asked to introduce the audience to the functional neurosurgery today, which was another major area of interest of him. These are my disclaimers, and I am sincerely thankful to Professor Kanchan Mukherjee, Professor Tipu Aziz, and Professor Patrick Blomstead for teaching me the nuances of this field. PGI Chandigarh is the leading team in STEREOTACTIC radiosurgery, clinical work and research. Functional neurosurgery is roughly defined with epilepsy surgery, stimulation surgeries, lesional surgeries, psychosurgery, radiosurgery. Now, depending on the place of your work, your institution, and the dynamics there, you might be doing some, or in rare cases, all of these areas. But one thing common to all of them is that functional neurosurgeons want to do research on the functional and the pathological aspect of the brain. If you just go through the program of the next 3 days, you would be able to realize how intricate and complex is this art, full of the nuances. N number of different types of hardwares, softwares, generators, atlases, and you need precision to the sub-millimetric accuracy. After the introduction of the first stereotactic frame in 1908, the biggest breakthrough was in 1947 when Spiegel and Weisses targeted intracranial structures with pneumoencephalograms. And the most significant advancement happened when the Lexel improvised the already existing frame to an arc and radius based frame. This frame had a precision of some millimetric accuracy and it had an adjustable position of the arc. Now you have a luxury to target any no man's land of the brain regardless of the trajectory and angle of insertion. It wouldn't be an exaggeration to say that the history of lesional surgeries and, for that matter, functional neurosurgery parallels the history of the management of the Parkinson's disorder. 1967 was a landmark year because in that year, levodopa for the Parkinson's disease was introduced. In the era of lesioning, there were pallidotomies, thalamotomies, right, left, and center. There was significant improvement, but definitely the radiology was not that much robust. And sometimes the results were not consistent. So they may recur after a year or after that. Lesional surgeries were doing for nearly every movement disorder, any psychological disorders. With non-availability of the sophisticated radiodiagnosis machines, accuracy was always questionable, and the temporary stimulation was often used to verify the correct position of the target before lesioning. Levodopa was a wonder drug, and the Parkinson's disease was considered to be cured. And under its influence, the number of stereotactic lesional procedures significantly reduced. But soon we realized that there are complications even after Parkinson's, and it is not a panacea. So in 1987, Professor Benevit took an electrode, placed it permanently inside the brain. He showed that that electrode is non-inflammatory, it doesn't cause any destruction. He connected it with a generator, changed the parameters, and it worked. It actually became a paradigm shift in the functional neurosurgery. In 1991, FDA approved unilateral VIM DBS for essential tremors. In coming years, it got approval for bilateral placement for a variety of neurological disorders, including OCD, PD, dystonias. Now, people have accepted that the long-term medication is more dangerous than a surgery in the head. The indications for the different kind of functional surgeries nearly remained the same, and even after a 2-decade experience in DBS, it was realized that DBS is not needed for every movement disorder, and it has its own set of complications. Patients with DBS never feel cured because there is an implant inside them and they feel like under some control of some external agency, and there are limitations of the cost, compliance issues, which are especially in the field, especially in the countries like India, where the cost is a major deterrent for choosing different treatment modalities. So I believe it is necessary to know both the procedures, and every patient, every treatment option has its own set of indications and contraindications. What we have been using with DBS is an invasive stimulation, and the last 1 decade, transcranial magnetic stimulation has really taken off, especially for the psychiatric disorders. Some of the studies have shown more than 70% improvement or cure rate in the medically resistant depression. It's not possible to cover each and every aspect of the neuromodulation today, but looking at all these indications, giving them all these names, I just want to give you an idea that anything you want to do, you can actually do today, and the industry and the technology are there to support you in this. Concepts in the epilepsy surgery evaluation have evolved significantly. We are now mostly dealing with a focus for the epileptogenic zone inside the brain, which may be surrounded or not surrounded by an eloquent area. No doubt, for most of our patients, the most desirous outcome is the best possible seizure control. You may need to be very radical with that. But at the same time, the most important, desirous part is to maintain the patient's quality of life. With the passing time, we are now looking at the epilepsy more of a network disease rather than as a focal disease. We are now more aware of the temporal dynamics of the activity of the brain with fast propagation of the activities, which has been grouped by the high resolution of the images and the electrical source imaging. There are parallel and sequential activation of various hubs of epileptic activity. And this is the exact same time when we need to innovate and improve our understanding with the ongoing research. This article from England highlights the current problem of the stagnation in the epilepsy surgery. This is the seizure-free outcome of the patients, and in the last 15 years, there is no significant improvement in the outcome of these patients despite our so-called improvement in the technologies and armamentarium. So perhaps we are still having many loose threads and we need to find answers to these queries. I am a gamma knife radiosurgeon. Especially for epilepsy, for some particular indications, I use gamma knife radiosurgery and I have found impressive results, which I would detail in my talk on radiosurgery. So there are different ways to skin a cat. You have several options now, but the long-term efficacy are only available for resective surgeries and SRS. Among other options like LITT and all that, we have the short-term results and we need to evaluate these on the long term. So the epilepsy surgery has enormous cross-fertilization between clinicians and researchers. This is a paradigm shift as a network disease. We can now have a tailored approach and an early preventive approach with the development of alternative treatment concepts. Coming to the psychosurgery, when looking at the archaeological material, it seems as if our ancestors were fond of taking out anything considered to be the bad blood inside the body. In Greece, cardiocentrics like the Aristotles claimed that heart was the center of the cognitive faculties while the brain did only cool the blood. Encephalocentrics like Plato identified the brain as the center of the higher cognitive faculties. Air was inhaled and transported to the cerebral ventricles where it was converted to pneuma, the substance which was responsible for the cognition and controlling the body. And there is now enough literature which shows that modern DBS has significant advantage for a variety of psychiatric disorders. But I find that the DBS for psychiatric disorders couldn't progress like for the movement disorders, and the psychiatrists are actually partly to blame for it. In order for DBS for the psychiatric conditions to improve, we need psychiatrists to support and lead the development. I have recently written this article after the Mental Health Act. Similarly, STEREOTACTIC radiosurgery is a completely non-invasive way with the early lesioning, high dose and functional indications. Its results are phenomenal with obsessive compulsive disorder. This is a case of essential tremor. So in the movement disorders, I just did a VIM Hamartoma, published it into Acta Neurosurgica, and the patient within 6 months developed a lesion and gave a beautiful So looking at the indications, functional disorders are a major indication for gamma knife radiosurgery, and it includes nearly all kind of indications into it. But the majority is the pain procedures. A functional neurosurgery demands a balanced cooperation between clinical neuroscience, basic neuroscience, and information technology. A strong bond between these fields is desired, which can shape the future of this field. So I am thankful to my colleague, not my colleague, my mentor, Professor Antonio Di Sales, and wish you a very learning conference. Thank you so much.